Hey guys, welcome back with our new topic, local anesthesia, part 1. In this part, we will discuss about introduction of to LA, means we will tell what is a local anesthesia, about its history, how it's discovered, how to define it, what are its desirable properties, what are the theories behind its action, and what the exact mechanism of local anesthesia and how some factors affecting the local anesthesia action. Local anesthesia is a cornerstone of oral surgical procedure, allowing for painless surgical and diagnostic procedure without the need for general anesthesia. As we all know, pain is an unpleasant experience consisting of pain perception and pain reaction. Pain perception is uniform for all the patients, as it contains a noxious stimuli which generate action potential, that is the impulse, and that will lead to the prey. And then comes the pain reaction, which is different for all the persons, as it is a response given by the brain to the periphery, but it is not only the response, it also contains some emotional component or some psychological component also. So pain reaction is different from the pain perception. So perfect pain management not only eliminate the patient anxiety effectively after they come to clinic, but also makes the operation process undisturbed. Both of which are positive to treatment outcome. So it has been reported that pain of the patients undergoing for tooth extraction usually reach its peak within 6 to 8 hours after surgery. So, pain in dental treatment is the root cause of dental phobia, especially in children. So, by targeting a specific area of the body, local anesthetics enable the oral surgeon to block the sensation, ensuring the patient comfort, ensuring the patient safety. So, comfort, safety, and reduction of the phobia is done with local anesthesia. History dates back to the 1844 with the Horace Bell, who discovered nitrous oxide as an anesthetic agent. So then William Thomas Green Morton in 1846 discovered ether. So these are both dentists. So dentists, not medical doctor, were responsible for the discovery of anesthesia. Given their close day-to-day contact with pain, so their motivation to seek the means to alleviate it. Then, first nerve block given was of cocaine, which is discovered or introduced by Carl Kohler. Then William Halsted used it for the nerve block in dental surgery, and in 1905 Alfred Enforth introduced procaine, which became widely used in dentistry. And in 1943, Niels Nofegren developed the lidocaine, offering safe and more effective anesthesia. Today, modern local anesthetics, just like napivacaine in 1960, bupivacaine in 1983, and atricaine in 2000, provide safe and effective pain control for oral and maxillofacial surgery. So, how to define the local anesthesia? Local anesthesia refers to a kind of anesthesia that injects drugs to specific sites. This stops patient pain and retain their consciousness. The advantage of this procedure is to avoid systemic medication for patients and also do not need to wait a long time for recovering from the general anesthesia. So, according to Melamed F. Stanley, the local anesthesia is defined as loss of sensation in a circumscribed area of body caused by depression of excitation in the nerve ending or inhibition of conduction process in the peripheral nerves. So, there are many methods to induce the local anesthesia, just like mechanical trauma, that is a compression of the tissues, low temperature, anoxia, chemical irritants, then neurolytic agents such as alcohol and phenols, and last but not the least, chemical agents such as local anesthetic agents. There are few desirable properties which a local anesthetic agent should have. It should not be irritating to tissues to which it is applied. Then it should not cause any permanent alteration of the nerve structures. Its systemic toxicity should be low. It must be effective regardless of whether it is injected into tissue or is applied topically on the mucous membranes. The time of onset of anesthesia should be short as possible. The duration of action must be long enough to permit the completion of the procedure, yet not so long as to require an extended recovery. It should have potency sufficient to give complete anesthesia without the use of harmful concentrated solutions. It should be relatively free from producing allergic reactions. It should be stable in solutions and should readily undergo biotransformation in the body. It should be sterile or capable of being sterilized by heat without deterioration. No local anesthesia in use today satisfy all these criteria. So all the anesthetics do meet most of them. The theories regarding local anesthetic action. So there are many 5 theories. Number one of which is acetylcholine theory, then calcium displacement theory, then surface charge theory, then membrane expansion theory, and new one is specific receptor theory, which is widely accepted theory nowadays. Okay, first acetylcholine theory. This is older historical theory, not accepted today. It is proposed that acetylcholine is involved in the transmission of nerve impulse along the peripheral nerves. According to this theory, local anesthetics prevent the release or action of acetylcholine, so blocking the nerve impulse conduction. Later researches showed that peripheral nerve conduction does not depend on acetylcholine. Instead, it depends on the movements of sodium and potassium ions across the nerve membrane. So this theory, that is the acetylcholine theory, has been discarded. Next one is calcium displacement theory. Local anesthetic displaces calcium ions from the nerve membrane, reducing sodium permeability and blocking impulse transmission. But it has a limitation. Evidence that varying the concentration of calcium ion within a nerve does not affect local anesthetic potency, which decreases the credibility of this theory. That means, if calcium ions are more or less, whether it's more or whether it's less, it does not affect the local anesthetic potency. Third one is surface charge theory. According to this theory, local anesthetics change the electrical surface charge of the nerve membrane, which makes sodium channel less likely to open. But current evidence indicates that resting potential of the nerve membrane is unaltered by the local anesthetics. They do not become hypopolarized, they remain polarized. And that conventional local anesthetics acts within the membrane channel rather than at the membrane surface. So, the surface theory cannot explain the activity of uncharged anesthetic molecules in the blocking nerve impulses, like benzocaine, in the case of benzocaine. And in this diagram, you can also see there are two forms. One is cationic form and one is base form. So, according to this theory says the cationic form change the electric change its electrical potential, electrical surface of the surface charge of this membrane, nerve membrane. But what will then basic form do? As we all know, according to today's theory, basic form is diffusible form, which required for entrance into nerve membrane. But in surface charge theory, this theory says cationic form is responsible for changing the electric membrane potential, which we know in today's concept, the electric potential does not change. So this theory also has this limitation. Next one is membrane expansion theory. Local anesthetic expand the nerve cell membrane, which altered the sodium channel function. It means decreasing its permeability and preventing nerve conduction. However, no direct evidence suggests that nerve conduction is entirely blocked by membrane expansion. Last one is specific receptor theory, which is widely accepted today. And this, according to this theory, local anesthetic binds to specific receptors on the voltage-gated sodium channels, which block the nerve impulse conduction. It appears that drugs can alter nerve conduction in at least 4 sites within the sodium channel. Number 1, within sodium channel, example lidocaine, atropine, naproxen, lidocaine, and bupivacaine. Second one, at the outer surface of sodium channel, saxitoxin, tetrodotoxin. Third one, at the activation gate, scorpion pinom. Fourth one, at the inactivation gate, scorpion pinom. So, how exactly local anesthetic work to block the nerve conduction? What our theory says. The primary action of local anesthetic in producing a conduction block is to decrease the permeability of ionic channel to sodium ions. Local anesthetics selectively inhibit the peak permeability of sodium, whose value is about 5 to 6 times greater than the minimum necessary for the impulse conduction. So, local anesthetic displace the calcium ion from the sodium channel receptor, which permits the binding of local anesthetic molecule to its receptor sites, which produces the blockade of sodium channel and decrease in sodium conductance, which leads to depression of rate of electrical depolarization and failure to achieve the threshold potential level, along with lack of development of propagated action potential, which is called conduction blockade. So, mechanism by which sodium ions gain entry to the exoplasm of nerve, thereby initiating the action potential is altered by the local anesthesia. The nerve membrane remains in polarized state, which fails the surface charge theory. So, nerve membrane remain in polarized state because ionic moments responsible for the action potential fail to develop. Because the membrane's electrical potential remain unchanged, local currents do not develop and self-perpetuating mechanism of impulse propagation is stalled. An impulse that arrived at a blocked nerve segment is stopped because it is unable to release the energy necessary for its continued propagation. So, nerve block produced by local anesthetic is called non-depolarizing nerve block. Now comes to the mechanism of action of local anesthetic. How local anesthetic work exactly it depends on 2 factors. One is diffusibility and another one is binding, which is responsible for local anesthetic effectiveness. So the former, that is diffusibility, is extremely important in practice. The ability of local anesthetic to diffuse through the tissue surrounding a nerve is of critical significance because in clinical situation, local anesthetics cannot be applied directly to nerve membrane and it can in a laboratory settings as it can in a laboratory settings. So local anesthetic solution better able to diffuse through soft tissue provide an advantage in clinical practice. So how this local anesthetic work? It available as a acid salt for clinical use. The acid salts of local anesthetic, both water soluble and stable, is dissolved in sterile water or as well as in saline. In this solution, it exists simultaneously as uncharged base form and positively charged cationic form. As the pH of solution is acidic, so hydrogen ions are also present. Relative proportion of each ionic form of solution vary with the pH of the solution or surrounding tissue. In case of high concentration of hydrogen ion, that is, in case of low pH, means in case of acidic environment, like in inflamed tissue, when there is inflammation, then there is low pH. The equilibrium shift to the left, means cation forms more formed. And for the entry into nerve membrane, we need base form. And for binding with the receptor, we need cationic form. So, whenever there is inflamed tissue, why action of La decrease? Because in case of inflamed tissue, pH is low, and due to which low pH, cation form is more and base form is less. And when base form is less, then no entering into nerve membrane. And if there is no basic involvement, then equilibrium shift toward right side, means base form more. And then relative proportion of ionic forms also depend on the pKa, that is the dissociative constant of the specific local anesthetic. pKa is a measure of affinity of a molecule for hydrogen ion. When pH of solution has same value as the pKa of local anesthetic, exactly 50% of drug exists in the cation form and 50% exists in the basic form. So two factors involving in the local anesthetic, as I have told before, diffusion of the drug through the nerve sheath and binding at the receptor site of the ionic channel. So the uncharged lipid soluble base form of the anesthetic is responsible for the diffusion into the nerve sheath. So we can take an example that 1000 of local anesthetic with pKa 7.9 is injected into the tissue outside the nerve. Tissue pH we can take 7.4 like in first diagram. At normal tissue pH, 75% of local anesthetic molecule are present in cationic form and 25% present in the basic form. Like here in this diagram, we have shown the 1000 molecule if are taken, then its 75% become the 750 and its 25% 250 basic form. So 250 basic lipophilic basic form will diffuse into the nerve sheath to reach the interior exoplasm. When this happens, the cation form equilibrium cation form or base form equilibrium disrupted by passage of base form into the neurons. The remaining 750 extracellular cation form will now re-equilibrate according to tissue pH and the pKa of drug, that is the now 25% of this 750, that is 180, convert into base form and remaining 570 cation form. So 180 newly created lipophilic basic form again diffusing into cell, starting the entire process again. And inside the exoplasm, basic form is more. So it's again equilibrium started and it convert into cation form, and that cation 250, 70%, 75% of 250 it become cation form. It is 180 cation and 70 remain as a base form. So 180 cation attached with at the receptor site, attached at the receptor site. But in reality, this does not happen. In reality, not all the LA molecule will eventually reach the interior of the nerve. Why? Because of the process of diffusion, drug will diffuse in three-dimensional patterns, not just toward the nerve, but some of it absorbed into the blood vessel, some of it absorbed into extracellular soft tissue at the injection site. So, when after penetration of the nerve sheath and entry into exoplasm by the basic RN form, re-equilibration I have told you occur, and because LA cannot exist only in the base form at the intracellular pH of 7.4, so 75% of base form revert into cation form and remaining 25% remain as a base form. So, from the exoplasmic side, the cationic form enter the sodium channel, bind to calcium receptor site, and ultimately responsible for the conduction blockade. So this diagram is clearly shows all the process